Next question. A 70-year-old man stopped smoking at age 50. He asks about lung cancer and wants to know if he might get it. He was an accountant his whole life and lived in a suburban household. He has coronary artery disease, for which he takes a beta blocker, aspirin, ACE inhibitor, and atorvastatin. He has no pulmonary symptoms, and his vitals are normal. In regards to screening, what should you offer this man? A. Low-dose CT scan of the chest every year. B. Low-dose CT scan of the chest every 3 years. C. Low-dose CT scan of the chest every 10 years. Or D. Reassurance. And the correct answer is D. Reassurance. Lung cancer screening has a very specific set of criteria. The modality that is offered is a low-dose CT scan of the chest annually until you no longer fit criteria. And these are the criteria we need to remember. So there's 3 criteria. Number 1, age 55 to 80, and a 30-pack year plus history of smoking. And if they quit, the quit date has to be within 15 years prior, which means that you don't have to get screened if you are less than 55, have a less than 30-pack year history, or if you quit longer than 15 years ago. And then the other one that I'll go ahead and add on is also we don't do screenings in patients older than age 80. So that's our lung cancer screening guidelines, and those will be important for you to remember. Next question. A 56-year-old man has a 20-pack year history of smoking. He is an active smoker. CT scan for a PE is negative, but he has a pulmonary nodule. It is 1 centimeter in size with a spiculated surface with calcifications near the center and no nodes or other masses. Which of the following increases the suspicion for malignancy? A. Its size. B. Its appearance. C. The patient's age. Or D. The absence of nodes nearby. And the correct answer is the appearance of the nodule. So when you have a pulmonary nodule or mass, the first consideration should be, is this high risk or not? Here are the things that we need to remember that increase the risk of cancer or increase the likelihood that this is cancer. So size greater than 2 centimeters, that's an important cutoff. Spiculated appearance, which is the one we're referring to in the vignette. Age of the patient greater than 70. And a smoking history, more likely to have cancer. That just makes sense. But some good ones to know is perhaps a wrong answer choice could have been the presence of calcification. A lot of times people will get that confused. Remember that actually that does not mean it is more likely to be cancer. Things that decrease the cancer risk are a size less than 8 millimeters, smooth appearance, lack of smoking history, and an age less than 45, less likely to be cancer. The board's insider tip for this is note that there are huge gaps between the age and size. There is a lot of equivocal data, which should be counted towards cancerous on the test. Next question. A 62-year-old man is evaluated for a pulmonary nodule. He received a CT scan with IV contrast for evaluation of a pulmonary embolism last week. That was negative. He was treated, however, for bronchitis. That CT scan found a 9 millimeter nodule in the right upper lobe, just adjacent to the pleura. He smoked 30 years ago, worked in a shipyard, and has otherwise been healthy. What is the next step in the management of this patient? A. Biopsy the lesion. B. Reassurance. C. Repeat CT scan in 6 months. Or D. Review old imaging. The correct answer is review old imaging. So this is a classic board question. Regardless of how much guidelines change, if there's old imaging available, always first compare it now to then. A stable nodule over time is the most reassuring piece of evidence there is. Next question. A 72-year-old man comes in with a pleural effusion. The effusion is determined to be loculated by X-ray and ultrasound, but a pocket large enough for diagnostic thoracentesis is found. The fluid is drawn and sent for laboratories. Fluid pH is 6.9. The color is serosanguinous. Leukocytes are normal. Erythrocytes are many. Cytology shows atypical squamous cells. Lactate dehydrogenase level is 425. Effusion lactate dehydrogenase to serum lactate dehydrogenase ratio is 1.2, and the effusion protein to serum protein ratio is 0.8. Which of the following is the most likely diagnosis? A, congestive heart failure, B, pneumonia, C, malignancy, or D, tuberculosis? And the correct answer is malignancy. So this question is trying to determine if you can interpret fluid studies. The most common thing and the first thing to do on fluid studies is to assess whether there's transudate, which is hydrostatic causes like CHF, or exudate, which is oncotic pressures like anything bad, infections, TB, and cancer. That's done with Light's criteria. Remember Light's, but then you must know what likely will be found for each disease. So the important ones to remember for this criteria is that a ratio of pleural fluid to serum LDH greater than 0.6, you're going to consider that an exudate. A ratio of pleural fluid to serum protein greater than 0.5, again, you're going to consider that exudative. And a Boards Insider tip is that leukocytes are usually seen in infection, red cells seen in cancer and hemothorax, and cytology is positive in cancer. Next question. A 67-year-old man is seen in the ED for shortness of breath. He has a 100-pack-year history of cigarette smoking. His vitals are normal. CT scan of the chest reveals there is a pocket of fluid that does not layer out when the patient is supine. What is the next best step? A, lung biopsy, B, expectant management, C, thoracotomy, or D, thoracostomy? And the correct answer is D, thoracostomy. So the question is about the management of a pleural effusion and the indication for surgical procedures. While thoracentesis is useful if it's not loculated, when a loculated effusion is encountered, there must be some sort of surgery. The first step is to place a chest tube, that's the thoracostomy, and then proceed, if needed, to decortification with a thoracotomy. Notice the absence of the S. Chest tubes allow for semi-permanent placement and continuous drainage of fluid while the primary cause is fixed. Next question. You are consulted on a 47-year-old man for a pleural effusion. He has a history of CHF. The X-ray shows an effusion of about 3 centimeters in height. It is free-flowing, and ultrasound shows that it is not loculated. His vitals are normal. There are no masses. Physical examination reveals the pleural effusion. What is the best next step in his management? A, diuresis, B, empiric antibiotics, C, thoracotomy, or D, thoracostomy? So there are plenty of considerations to treating a pleural effusion. The first is to decide if it is loculated or not. This one isn't. The next step is to assess for a history of CHF. If there is a history, you're going to diurese the patient first, and almost regardless of the cancer risk, if it goes away, then the diagnosis is from the CHF. If it doesn't resolve, the assessment continues. But the takeaway is that there is CHF and a pleural effusion. You should attempt to diurese first. Next question. A 67-year-old man is seen in the emergency department for shortness of breath. He has a 100-pack-year history of cigarette smoking. His vitals are normal. CT scan of the chest reveals that there is a pocket of fluid that does not layer out when the patient is supine. What is the next best step? A, lung biopsy, B, thoracostomy, C, thoracentesis, or D, thoracotomy? And the correct answer is thoracostomy. So this question is about the management of a pleural effusion and when surgery is indicated. While thoracentesis is useful if it's a non-loculated, when a loculated effusion is encountered, there must be some sort of surgery. The first step is to place a chest tube, that's the thoracostomy, and then proceed, if needed, to decortification with a thoracotomy. Notice the absence of the S sound in thoracotomy versus thoracostomy, so they can be a little confusing. Chest tubes allow for semi-permanent placement and continuous drainage of the fluid while the primary cause is fixed. Next question. A 23-year-old woman comes in with dyspnea. She is found to have a pulmonary embolism on CT scan. Her vital signs show a heart rate of 130, blood pressure of 80/60, respiration rate are 24, and her temperature is 98.6 with a saturation of 82% on 15 liters non-rebreather. Her BNP is 2,556, troponins are 5, and a 2D echocardiogram shows a D septum. In regards to the pulmonary embolism, what is the next best step in the management of this patient? A. Apixaban. B. Heparin infusion. C. Tissue plasminogen activator. Or D. Warfarin. And the correct answer is tissue plasminogen activator. The patient is experiencing a massive pulmonary embolism. Pulmonary emboli, regardless of their physical size or location, influence pulmonary artery pressures. It is the hemodynamic response to the PE that stratifies how severe it is, not the CT scan findings. Here, with the troponins being elevated, the BNP elevated, and a D septum on echo, the patient has at least a submassive PE. With compromise of hemodynamics, frank hypotension and hypoxemia, this patient is determined to have a massive PE. It's treated with TPA. Next question. A 67-year-old woman comes in with a swollen leg. She smokes, has a history of colon cancer status post-resection, and is now cancer-free. Her vitals are normal. Her right leg is 3 centimeters in diameter longer than her left, and she has edema distal to the shins to the toes. An ultrasound reveals an acute DVT. What is the best next step in management? A. D-dimer. B. Heparin infusion. C. Rivaroxaban. Or D. Tissue plasminogen activator. And the correct answer is Rivaroxaban. Easy peasy, the treatment for a DVT is either low molecular weight heparin bridged to warfarin or a novel oral anticoagulant. The only option in this question that is exclusively correct on its own is Rivaroxaban. Remember, we can't just start warfarin. We have to do a bridge first.